So our patient didn't resolve at step 3, the anterior repositioning appliance. What do? You move to step 4. Now remember, there are 5 different types of night guards that can be made for a patient. We've attempted 2. We've attempted a mandibular splint, and we've attempted an anterior repositioning appliance. The third type, which is very popular for people, is to make a splint on the upper and a splint on the lower, or to make a very thick night guard. In this case, what we're going to do is remove the beads. Once the beads have been removed, we're actually going to add the upper member of the MyTap, but there'll be no protrusion involved here. We're simply doubling the vertical dimension at step 4. Who might like a doubled vertical dimension? Well, somebody that's got a very constricted arch may like it. Someone that has a large tongue looking for more room may like the addition of more vertical dimension. If the patient's airway problems don't resolve with step 3 of the protocol, now we're going to turn to step 4. The goal is to produce a night guard that's twice as thick as in step 1. So we're going to return to placing the mandibular night guard, but it will be opposed by a maxillary night guard. Therefore, in the laboratory, what we have to do is remove the beads that we placed at step 3, add the stick back into the lower appliance, and then make a maxillary appliance to oppose it. First step is we're going to take a buffalo knife and engage the beads and simply twist and pull them off. Now, when you do this, make sure the knife is always moving towards the table, just in case it flies free. The second thing that will happen is it may not peel up quite as easily as this one is. Sometimes it binds to the thermoplastic material. You end up having to work pretty aggressively to get it off. Can you use an acrylic burr? Absolutely you can, but it actually gunks up the acrylic burr, makes it a little more difficult to do. We typically like to just try to pry it free simply with a knife. The other is it will remind you next time not to flame the surface so aggressively. Remember, we're going to step 3. We're checking for 2 or 3 days at step 3. At best, if they like it, we're going to go another week before we decide to make a final appliance for them. So let's say it's 2-3 weeks max that you're having to have them wear this. You don't need to be so aggressive at flaming such that the beads won't want to come off very easily. It's a mistake that we all make. We learn from it, and the next time when you flame the appliance, you'll do it for less time. The worst that will happen is that the beads will fall off early. Patient will note that, call you, and you simply bring them in and do it again. I'd much rather fight the beads falling off than have to continually try to dig and dig to get the beads out. So, knife always goes toward the table, and then you end up pushing until the beads come free. Once the beads have been freed up, we're back to the step 2 mandibular night guard. We take our stick that we removed at step 2 and replace it on the appliance, and we're ready to actually turn this into a traditional type of sleep appliance, one that has an upper and a lower that connect together. However, at step 4, we're not going to protrude that device at all. So, beads were removed and the stick was replaced in our lower member of our MyTap. Now we've got to get the upper member of the MyTap molded to the patient's mouth. Now we're actually going to make the maxillary appliance. The maxillary appliance is made of exactly the same material as the mandible. It's treated the exact same way. We pour hot water on top of it. We allow it to turn clear, and when it turns clear, we go to the mouth and begin shaping it. So, now we have it clear. It's time to take it to the mouth. The key here is making sure you get around the cheeks and it doesn't allow the phalanges to fold down and be caught on the occlusal surfaces of the teeth. Okay. When you seat it, you want to make sure it comes directly out of the anterior so that the protruding rod, when it connects to it, is not going off at an angle. Bite down, bite medium hard again, Close your lips around it and just kind of suck against it. We're going to wait 4 minutes for it to set up, and at that time we'll remove it and quench it again to complete the set. After the 4 minutes have set up, you can ask the patient to actually reach in and remove it. You'll feel the flanges up high. Just pull down on it. Nice. Beautiful. You can see it nicely adapted to the teeth. We need to complete the set by actually quenching it in cool water. After the upper member has cooled, you actually want to join it together with the lower. So there's a hole on the upper, a rod on the lower, and they join together. Now, common mistake. You have to make sure the biting surfaces are away from one another. You can't have it turned where the biting surfaces are in, because that's not the way that we're made. When you go to the patient, teach them to put the upper in first, then reach with the lower. Because later we're going to be protruding this further, and we want to make sure that they're always reaching with the lower rather than trying to do it the other way. So take it as a unit, put the upper in first. Now reach and find the lower. Good. Now at night when they have this in, we don't even put the little nut on here to hold them at all. She has full freedom to move forward, back, all around. But as she falls asleep, her jaw will drop back. At what vertical dimension? At actually double the vertical dimension that we had before. So this is like making a night guard on the lower, a night guard on the upper that oppose one another. It's self-equilibrating because she's going to just slide until she finds that comfortable position. Here's the issue though. In order to fabricate this appliance, we actually have this rod that comes out through the lips. Step 1 of the protocol was teaching her how to breathe more effectively through her nose. We even used pieces of tape and nasal dilators in order to make sure that she was breathing through her nose. And now I put something that actually prevents her from doing it as easily. In the first iteration of this protocol, we would use tape and put tape all around. But we finally went to the company and said, is there something you can do to assist us? So they made an obturator, something to block the airflow for us that we can add to this appliance quite easily. So, would you remove it? Take the lower out first. It's the opposite of putting it in. Lower comes out first, and we'll reach in and take out the upper. Quite a tight fit. If you have a tight fit, what we're going to do is we're actually going to heat the appliance up lightly, and we're going to move it around so as to make it a little easier for her to get it out. So when the fit is a little too tight for the patient to be comfortable, just lightly dip it in the hot water again. You don't need it to turn perfectly clear, you just need to soften. Put it back in for me. While it's in, what we're going to do is move it back and forth, kind of wiggle back and forth on it. It creates a little space on the teeth. So hopefully we end up getting a little bit easier when it finally the set occurs. The other way you can do it is trimming away at the material or taking a burr to it. And I found that anytime I start doing that to try to trim out anything, especially with a burr, that I end up creating nicks that make it more uncomfortable for the patient. It seems like moving it around is a much better way. So why don't you take it out for me now? Good. And we'll cool that down. All right, so now we've got it to where the appliance is more comfortable for the patient to wear. This is the obturator I was telling you about that helps us block off airflow for the patient. There are arrows that are showing what the direction is for the maxillary arch and the mandibular arch, and it simply slides onto the appliance where the stick will come through the hole and slides up against the appliance. Her lips will wrap around it and it will block airflow through. It's like a piece of tape worn internally. So let's let her put it in place. Try that for me. After you get it in place, you're then going to just sort of wrap your lips around the plastic. Plastic goes on the inside of the mouth, not on the outside of the mouth. If the plastic extends too far, what you can do is actually take a scissor and trim it a little shorter. But don't get it all the way to the corners of the mouth or it'll want to work its way out. Now it makes her have to breathe through her nose when she has the appliance in place. This obturator will be used on steps 4, 5, and 6. It gets our patients to where they're breathing through their nose even though they have more vertical or in 5 and 6 more protrusion. So you've now seen how to create the provisional dual arch orthotic, the one that increases or essentially doubles the vertical dimension from step 2. What do you do now? Well, you give the patients 2 or 3 days, you give them a call and see how they're doing. If they happen to like this step, then you give them another 7. If they continue to like it after 7, you send them home with the screening tool that they began with. If you get positive responses all the way, then that becomes your control strategy. So you go to the doctor and say that step 4 seems to be working successfully for my patient. What do you do now? The doctor will tell you to make a final appliance. What kind of final appliance? Well, they'll direct you because there are many different varieties under step 4. They could ask you to make one appliance on the upper and another on the lower. They could ask you to make a thicker appliance. They could ask you to make one in the upper, one in the lower with a little anterior deprogrammer. It's going to be up to the doctor to replicate the advantage of step 4 in this final appliance. The beauty of the protocol, though, is you've already walked through and the patient has shown you that this is the appliance that's appropriate for them. Now, what is the doctor going to do in the office with that information? Once the patient is under control, then they're going to say, how can I weave this into my resolution strategy? If I have to gain that much oral volume in the final resolution strategy, I'm probably thinking orthodontics with some sort of surgical intervention strategy. Maybe I'm making corticotomy cuts, or I'm doing surgically assisted rapid palatal expansion. Maybe it's even orthognathic. It could be, though, that a person is seeking that much volume because they just have a big tongue that won't fit and out of their airway. And in fact, an ENT might be a perfect person to refer that patient to. They'll also have patients that you call up at the end of 3 days and say, how are you doing? And they'll tell you, I'm still having the same problems. This isn't the right appliance for me. In which case you move to step 5 of the protocol.